Hi everyone, as promised in the last video, I am back with more topics on gout, as I will be covering gout medications today. If you have not done so already, please go watch my last video which covered ACR's 2020 guideline on the management of gout, which will complement this lecture nicely. I am very excited about today's topic because whether you're a medical student, an intern, a resident, or a rheumatology fellow, I think there is going to be something useful for everyone. Let me tell you what this lecture is not about. Today's lecture won't necessarily cover the med dosing, mechanism of action, all the possible side effects, especially in that order like how you used to study in medical school for pharmacology. I think you can easily look up that kind of information on your phone when needed. Instead, what I'm going to do today for you is to give you pointers on what kinds of information you need to focus on during your clinical training. Example, what kind of questions are they going to pimp you with, or the questions you can anticipate from your preceptors so you can look super smart, and also the favorite questions asked on the boards. As always, my lectures on YouTube are meant to supplement, not replace your studies, so make sure you spend time reading the topic of gout management on your own. Okay, so let's get started. So overview of today's talk. It's divided into two parts. Part A will discuss flare management. Part B will cover urate lowering therapy. Let's get started with Part A. Unless you're a rheumatologist, there are three meds that you're going to focus on here. Number 1, NSAIDS. Number 2, steroids. Number 3, colchicine. If you're a rheumatology fellow, IL-1 inhibitors and ACTH may become a treatment option for you as well. As far as I know, these are not easily accessible or tolerable and are not tested much on the boards. For today's talk, I'll focus on the first 3 flare medications. Pointer number 1. For all these above medications, it's very important to know when you can or cannot use each option. Simply put, you have to know the indications and contraindications. Let's briefly discuss NSAIDs and prednisone first. For NSAIDs, all you interns and residents out there, you generally avoid NSAIDs in the inpatient setting for various reasons. It could be because patients come in with decreased kidney function, or you're worried that they will develop decreased kidney function while they're in the hospital. Maybe they're not eating because they're NPO. Maybe they have history of gastric ulcers. There's so many different reasons why we generally avoid NSAIDs for people who are hospitalized. So for most cases, this won't be your number 1 choice while treating inpatients. For outpatient setting, you can do somewhat of a longer acting indomethacin, although other short half-life ones are fine too. So not much to comment here, just think of what kind of populations you generally want to avoid using NSAIDs in and then apply that idea to gout patients. Next, let's discuss prednisone. So can you think of an obvious case where you'll be very careful using steroids? Yes, diabetes. It's not that you cannot use prednisone in these patients, but let's say a diabetic patient cannot tolerate NSAIDs and colchicine. If it's monoarticular gout, then using an intra-articular glucoid injection may be an option for you. Prednisone can be life-saving, literally and figuratively in certain cases. Like some NPO patients in the hospital or patients who had organ transplants, And by the way, this is one of the favorite questions on the boards. They can give you a question stem of someone who just had a recent organ transplant. Let's say a kidney transplant, and they're taking cyclosporine, which is a common medication for post-transplant patients. There is an increased risk of neuromyopathy with concurrent use of colchicine with cyclosporine. So you sort of need to use steroids in this case. Also, NSAIDs is out of the option because you wouldn't really give that to someone who just had a kidney transplant. Third option, colchicine. So colchicine has many different indications like Behçet's, pericarditis, recurrent episodic stomatitis, etc. But right now I'm just focusing on treating a gout flare. By the way, colchicine is not FDA approved for CPPD, although you'll see it being used for CPPD. When it comes to colchicine, there's two things you need to study. Number one, drug adjustments and drug interactions. And number two, contraindications. They kind of go together. So starting with number one first. If you're studying for rheumatology boards, you'll unfortunately have to memorize these adjusted dosing for various adjustments. But here, I'll just tell you when you need to dose adjust. So number one, decrease creatinine clearance under 30. Number two, hemodialysis patients. Number three, CYP3A4 inhibitors divided into strong, moderate, and weak inhibitors. And lastly, P-glycoprotein inhibitors. So earlier I mentioned about how you would avoid using colchicine in an organ transplant patient because they're on cyclosporin. That's because cyclosporin is a P-glycoprotein inhibitor. So for all these medications, you need to dose adjustment for the times of number one, acute flare, and also number two, prophylaxis dose adjustments. They're all different dosing. So it's quite a lot of various dosing that you would need to remember for the purpose of the boards. But here, let's review what these medications are. So some of the examples of CYP3A4 inhibitors and P-glycoproteins would be macrolide antibiotics, azole antifungals, and calcium blockers like diltiazem or verapamil, also Coreg, and various HIV meds. So rather than memorizing what is a dose when someone is on clarithromycin and you have to give colchicine, just look up that information. But just remember, colchicine has many drug interactions with different medications. So know the classes of medications that you have to watch out for. The reason why I'm saying this is, practically speaking, if you know the general groups of medications you need to look out for, the exact dosing of whether to give 0.3 milligrams daily versus 0.6 milligrams daily, or whether to not repeat for 3 days or 2 weeks, etc. It's just easier and safer to look up to confirm. Okay, so number two, contraindications. Even though the above meds are not absolute contraindications, but something that needs dose adjustment, know that depending on their renal or hepatic function, you may need to avoid colchicine altogether. Pregnancy is also sometimes listed as contraindication for colchicine, although according to ACR reproductive health guidelines, colchicine is actually one of the meds on the go list along with Plaquenil, Imuran, and prednisone. A common side effect of colchicine is nausea and vomiting. So if you're in the hospital with someone who has gastroenteritis, probably not the best option for you. So to recap for colchicine, know that you need dose adjustment for someone with decreased renal function, someone on either CYP3A4 inhibitors or P-glycoprotein inhibitors, and watch out for those organ transplant patients. Let's move on to part B, urate lowering therapy. 3 classes of ULT, broadly speaking. There's number 1, xanthine oxidase inhibitors. In this class, we have Allopurinol and Febuxosgtat, which also goes by the brand name Urate. Number 2, Uricosurics like probenecid or lesinuride. And number 3, Uricase with pegloticase being the only one currently, the brand name of Crysdexa. Although I reviewed the indications for ULT in ACR's 2020 guideline video, let's still review them because they're important. So, strong recommendations, having 2 or more attacks per year, having 1 or more tophi. So at least if you have 1 tophi, then it's a strong recommendation to start ULT. And also radiographic evidence of having joint damage. For conditional recommendations, so someone who has less than 2 attacks per year, but more than 1 flare in their lifetime. Number 2, having CKD. And number 3, urolithiasis. Next, we have ULT prophylaxis. This is a very important point and often the point of confusion for many physicians who don't treat gout regularly, which is understandable, but it still causes a lot of discomfort and mistrust sometimes in patients. So for medical students, interns, and residents, if you don't take anything else from this lecture, just remember this point. I often heard this, someone coming in with a history of gout and they need to start ULT, and they will absolutely say no, 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 because in the previous time, my doctor gave me gout. So you'll hear this. Why did this happen? Well, this is due to starting ULT without any prophylaxis medications, most likely. You need to give prophylaxis for patients before you start ULT. And by prophylaxis, I mean you're going to give a flare treatment medication, as mentioned earlier, like prednisone, colchicine, or NSAIDs, but it may be a different dosing than when you are giving it for actual treatment of flare. And you need to do this ahead of starting ULT, although some people give it at the same time of starting ULT. ULT can precipitate gout flares, and if you don't give prophylaxis, patients will come back very unhappy. Even if gout flares with ULT, please don't stop or reduce ULT. And you may wonder how long one should continue prophylaxis medications. It's usually 3 to 6 months, because if you give less than 3 months, as we learned in the last video when we covered the ACR's 2020 guideline, they're more likely to flare. This is in comparison to the duration of ULT, which is for a lifetime. So ULT, you give it indefinitely. Prophylaxis is given for 3 to 6 months. And the options of prophylaxis, again, they're the same meds that you would treat a gout flare with: colchicine, prednisone, and NSAIDs. And how do you give it? Well, personally, I like giving prophylaxis first, at least for a few days, then starting ULT. Because if a patient has a reaction to the medication, I want to know which one is causing the issue. So which ULT to you is what we're going to cover next. This is also a review from last week's lecture, but given everything is the same and there is no obvious contraindications to any of the following medications, you want to start with xanthine oxidase inhibitor, especially the allopurinol. Allopurinol is your first line ULT treatment in gout patients. Let's talk more about allopurinol. First, AHS or allopurinol hypersensitivity syndrome. You need to know this. Allopurinol hypersensitivity syndrome is uncommon, but it is very serious. And this is where the HLA-B5801 testing comes in. Do you check HLA-B5801 in all patients taking allopurinol? No. According to ACR's 2020 gout guideline, just in Asians and African Americans, and by Asians I mean Han Chinese, Korean, and Thai patients. In terms of dosing, usually the dose of allopurinol starts at 100 milligrams a day and it's titrated up. But if GFR is decreased, then you can start at a lower dose like 50 milligrams a day and then titrate to a goal of uric acid level of less than 6. Earlier, when we were discussing colchicine for part A, we discussed an organ transplant patient who couldn't take colchicine given the fact that they were on cyclosporin. Let's say on the exam, this particular patient is also known to be on Imuran for a history of transplant. And patient is having gout history and multiple gout flares, and they need ULT. If allopurinol is one of the answer choices, it's probably the wrong answer, because use of allopurinol with concurrent use of Imuran can increase Imuran levels, leading to various toxicities such as increased infection rate or myelosuppression. This is because Imuran, in addition to being metabolized by TPMT, also gets metabolized by xanthine oxidase inhibitor. So that interaction is something that you want to be aware of, especially because in rheumatology office, you have a lot of lupus patients being on Imuran, and they could have concurrent gout flares. Okay, let's move on to Febuxosgtat. Febuxosgtat goes by the trade name Urate, and Urate does not need HLA-B5801 testing, but it still needs to be avoided when patient is on Imuran. Urate also has to be renal dosed, so usually patients get started on 40 milligrams PO daily with normal kidney function, and then the dose is increased to 80 milligrams PO daily. but for decreased renal function of creatinine clearance less than 30, max dose is actually 40 milligrams. One more thing that you must know about Uricase is the black box warning of cardiovascular death. I covered this in the last video, so I won't belabor the point, but remember, cardiovascular history is something you want to focus on before prescribing Uricase. Next class of ULT, we have Uricosurics. In the proximal tubules of the kidney, there are Urate 1 and GLUT9 transporters whose function is to reabsorb uric acid in the body. Uricosurics work on these transporters by blocking them so you're not reabsorbing the uric acid. Probenecid is inhibitor of Urate 1 and GLUT9 transporters, and prior to use, G6PD, due to the risk of hemolytic anemia, must be checked. Uricosurics cannot be used in patients with decreased kidney function, specifically creatinine clearance less than 30, and also they're not to be used in patients with urate kidney stones. Lesinurad is FDA approved for gout, but is no longer marketed in the US. Let's move on to Uricase. So pegloticase is the medication, and this goes by the brand name Crysvita. And Uricase has a really fun mechanism of action. So hypoxanthine goes to xanthine, and then it goes to uric acid. And xanthine oxidase inhibitors will block the pathway at 0.1 and 0.2. Uricase actually turns uric acid that is not soluble to soluble allantoin, and that is how pegloticase makes you pee out uric acid. During this process, body produces H2O2 with oxidative stress, so G6PD needs to be checked to prevent putting patient at risk for hemolytic anemia and methemoglobinemia. Pardon me for the typo, it should say uric acid, by the way. Yes, so you need to check G6PD because of oxidative stress, but there is something else you should be checking prior to giving this medication. Pegloticase is an infusion medication that is given every 2 weeks. And prior to each infusion, you need to recheck the serum uric acid level. Why? Well, the answer has to do with the infusion reaction, which is common with pegloticase, but we're mostly worried about anaphylactic reactions. And most reactions occur within the first few hours of infusion, although delayed type of hypersensitivity can occur. So prior to getting pegloticase infusion, patients will get pre-medicated with antihistamines, steroids, and other medications, but that doesn't always prevent the development of infusion reactions. So one thing we do is to monitor the pre-infusion serum uric acid level. Pegloticase works very well in terms of lowering serum uric acid level. As soon as you start the medication, you'll see the values dropping very fast to a value like 1 or 2 milligrams per deciliter. And let's say a patient's been getting pegloticase and their uric acid level has been checked and it's been consistently 1, 2, 1, 2. And then let's say you see the pattern of increasing uric acid level. Even if it's just a trend of it, your radar should be up. But if your serum uric acid level is greater than 6 milligrams per deciliter, you need to discontinue or cancel the planned infusion because this means you're losing efficacy due to anti-pegloticase antibodies development. And anti-pegloticase antibodies, it's not something that we check per se, but you could kind of know that the patient is developing the antibodies because of the increasing serum uric acid level. Going along with that, if you're gonna use pegloticase, just use pegloticase and don't mix it with any other ULT, because what you could potentially do there is to mask the loss of pegloticase efficacy or the development of anti-pegloticase antibodies. So today we reviewed 3 medications for the treatment of gout flares: NSAIDS, prednisone, and colchicine, which also can be used as prophylaxis as we learned today. And 3 classes of ULT, xanthine oxidase inhibitors, Uricosurics, and Uricase. I hope this lecture was helpful, especially in giving you a broad overview prior to your studies. And again, if you get a chance, try to listen to the video from last week's ACR 2020 guideline on the management of gout, which will be a nice complementary talk to today's lecture. As always, I'll try to come back with more materials that's clinically relevant and useful. And so until then, take care and good luck studying. Bye bye.